Now I feel relieved that I finished the silly part of physics. I hate physics. So I feel some sympathy with our radiologists colleagues actually. Okay, now we'll move to the normal lung ultrasound. We'll answer many questions about that. Which probe should I use? Where should I put the probe? What is the orientation of the probe on the screen? What are the normal findings I can get during the normal lung ultrasounds? Let's go through these questions. So first question, which probe should be used in the lung ultrasound? The answer is you can use all of them. The linear one with high frequency, short wavelengths, and the short penetration depth, as we mentioned before, it's very good at looking at superficial structures. So I would say if you want to check the pleural sliding very nicely, you should use the linear one. If you need to check for pneumothorax, because pneumothorax is superficial pathology, it's better to check with the linear probe, and so on. The other probe is the curvilinear probe, which should be used in deeper structure situations like pleural effusion, like consolidation. So each one is going to be useful in some situation. Superficial structures, so go with the linear one. Deep structure or deep pathology, go with curvilinear one. This is the phased array, the one we used for echo, and it can be used also for lung ultrasound as well. Where should I put the probe? We classify or divide the chest wall by parasternal line, anterior axillary line, posterior axillary line, to anterior part, anterior zone, lateral zone, and posterior zone, and each zone divided by horizontal line at the nipple level to upper and lower. So we have upper anterior, lower anterior. This is 1 and 2. Upper lateral, lower lateral, 3 and 4. Upper posterior, lower posterior, 5 and 6. So we have 6 areas on each side, total of 12 to be checked by the lung ultrasound. The third question, what about the probe orientation? On each probe you will find a marker or notch, or some companies make it like a green lamp here. So it's called a marker or indicator. And generally speaking, we do sagittal scans or horizontal scans. So if you are going to put the probe vertically, you have to make the marker looking at the patient's head side. If you use it for transverse scan, you have to make the marker looking at the right side of the patient. So the two famous scan planes, the sagittal plane and the transverse plane. This is the orientation. If you are going to use the probe sagittally, like this, so we point the marker of the probe towards the patient's head. This marker corresponds to the indicator on the screen. So the indicator now on the left side of the screen corresponds to the marker on the probe. Though the marker is looking cranially towards the patient's head, this means that the left side of the screen is the head side or cranial side or superior side, and the opposite side would be the caudal side or inferior. So superior, inferior. And the other plane, this is the probe, skin, superficial tissue. So this is anterior and go deeper and deeper till posterior. So we cut the patient sagittally on the longitudinal sections, and we look from the side, like this. That's why the aorta is being cut like longitudinal axis. So the marker towards the head, this is the marker side. So the left side is superior, right side is inferior. Superior, inferior, anterior, posterior. For the transverse scan, with the marker points to the right side of the patient, so this is the marker side, so this will be the right side of the patient, and this will be the left side of the patient, anterior and posterior. So we cut it similar to the CT scan. That's why the aorta here is a circular structure. IVC is the same, from the right to the left. So the marker or the indicator corresponds to this indicator on the screen. In chest ultrasound, we usually do the sagittal scans with the marker points towards the patient's head cranially, like this. Let's practice this example. Now, the right side of the patient, lung, diaphragm, liver, sagittal scan with the pointer or the marker towards the patient's head. So the orientation will be, so this is the marker on the left side of the screen. So this is the patient's head side, superior to the inferior, anterior to posterior. So from the marker side down, I should see lung, diaphragm, liver. This is the marker side. So lung on the left, then diaphragm, then liver. That's it. Does it make sense? This is about the orientation. Now, what are the normal signs I can get during normal lung ultrasound scan? First position, to put the probe sagittally, like this, on the anterior chest field, to cut two adjacent ribs and the space in between with the marker pointing towards the patient's head. So this is the marker on the screen. So the left side of the screen is the patient's head side, superior side or the cranial side, and this one is the inferior side and anterior to posterior. So this rib is the superior rib and this is the inferior rib. Does it make sense? As we mentioned before, the bone is impermeable to the ultrasound waves. So it's anechoic or hypoechoic with the rib shadow behind it. So what we can see now is the skin and subcutaneous tissue and then the intercostal muscle and a very, very bright line, which is the pleural line. Two ribs with rib shadows behind. And this is supposed to be the lung, which we can't see because the lung is filled with air, as we mentioned during part 1. So it's called simply PAT sign. The ribs and rib shadows are the PAT wings, and the lung tissue in between is the PAT body. This is the PAT sign. This is the beginning. Sometimes, because the pleural line is very reflective structure and very bright, very hyperechoic, it might have some reverberation artifacts or mirroring like this, which we can find it at similar distance between the probe and the pleura, and again, and again, and again. Those lines are just reflections from the pleural line. They don't exist in reality. They are called A lines. Normal finding and have no significant pathological value. This is normal. A lines, transverse lines, reflections from the pleural line. Now, we will look at the lung sliding. As you know, the pleura consists of two layers, parietal layer, visceral layer, sliding over each other. So we will see the pleura as if it's dancing, moving to and fro, backwards and forwards, like this. See that? Sliding. This is called lung sliding. It means that the two layers of pleura are close to each other, they can slide over each other, and there is no pneumothorax in between. Very normal finding and very reassuring that there is no pneumothorax. This is another example for lung sliding, very clear example. See, the pleura itself is moving backward, forward, to and fro. See that again. If you notice, there are some lines moving with the pleura. Sometimes called comet tails or Z lines. And again, it's normal. So lung sliding means no pneumothorax. This is normal. The next slide will get the M mode cursor and cut through this field like this. Let's see how does it look like. If we do like this, we'll find two distinct parts with the pleural line in between. The first part is the subcutaneous tissue and the muscular part, then pleura, then the lung underneath. So this is like sea shore sign. This is the ocean, this is the sand, and this is the lung movements during respiration. So it's called the M mode, called sea shore sign. Sea shore sign. This is normal. And again, there is no pneumothorax. This is another example. The pleural line, hyperechoic, in between two distinct parts, the muscular part, which is the sea, and the lung, which is moving with respiration, inspiration, expiration, is the sand. So this is sea shore sign. If we imagine that there is pneumothorax, so there is air between the two layers of pleura, taking the lung away, so the whole view will be like the sea, like this. There will be no seashore sign. We'll discuss that later in pneumothorax. Seashore sign. One of the common normal signs we can find is curtain sign. Curtain sign. When the patient takes a deep breath, the lung will dominate over the view, over the liver. So this is the liver, diaphragm, and the lung, this time on the right side, because the marker on the right side of the screen. See what will happen. Inspiration, see that. Again. Oh, this is the lung overlying the liver during inspiration. Curtain sign. This is normal sign. So quickly to recap and summarize the normal signs of lung ultrasound scan. First, on the anterior chest zone, we noticed the bat sign, two rib shadows, the lung in between, and the very nice bright hyperechoic pleural line. This is what's called bat sign. This is the pleural line and its reflections, which is called A lines, normal finding. And this is what's called lung sliding or pleural sliding. Which has very high negative predictive value for pneumothorax. This is another example for lung sliding. See, the pleura is dancing back and forth all the time. Then the M mode giving us the seashore sign. The muscular part is the sea, the pleural line, then the shore or the sand, which is the lung basically. Seashore sign. This is another example, seashore sign. Again, it means there is no pneumothorax. This is normal. And finally, curtain sign, when the lung encroaches over the liver during deep inspiration. Again, that was the normal lung scanning. The next part, we are going to discuss the findings of the lung ultrasound in abnormal conditions like pneumothorax, pleural effusion, and pneumonia. Wait for us.